Good morning, everyone. So yes, today we present our study on HIV drug resistance among first-line ERT experienced patients hospitalized with advanced HIV disease. In sub-Saharan Africa, a considerable number of patients hospitalized with advanced HIV are ERT experienced, so they are on treatment. And mortality among this group is extremely high during and following hospitalization. This is a reality we witness across various settings where MSF is working. So we suspect these patients are failing treatment, but data on virological response to treatment and drug resistance are very limited. And the current WHO treatment failure algorithm requires 2 consecutive high viral loads within 3 months before switching to second-line treatment. But in practice, this is often a lengthy process. And for clinically unstable patients, we can't afford to wait. So this patient was hospitalized in Congo at a very advanced stage of HIV, and he died of tuberculosis the day after this photo was taken. He represents very well the state in which most of the patients arrive at hospital. The overall objective of the study was to measure the proportion of treatment failure among hospitalized ERT experienced patients by assessing the proportion of patients with virological failure and describing the level of drug resistance. We also explored patient pathway to care and their experiences of diagnostic, treatment, hospitalization, and their relationship with adherence to understand how and why they present at such a late stage at hospital. The study was conducted in 2 hospitals supported by MSF in Homa-Bay, Kenya, and in Kinshasa, Democratic Republic of Congo. Homa-Bay County Hospital is a government hospital located in a small town, admitting both HIV-positive and negative patients in a province with 26% HIV prevalence, the highest of the country. The hospital in Congo is a MSF referral hospital admitting only HIV-positive patients in a low HIV prevalence context. Notably, in-hospital mortality is high, with 17% in Kenya, 26% in DRC. We conducted a mixed method facility-based study, and for the quantitative part, hospitalized patients living with HIV, 15 years and older, who had initiated first-line treatment at least 6 months ago and had CD4 below 350, were invited to participate. The data collection included a standardized questionnaire, CD4 count, and plasma viral load, genotyping for patients with viral load above 1,000 copies. And for the qualitative part, in-depth interviews with a subset of patients were audio recorded, transcribed, and translated, and then thematically analyzed. Drug resistance was interpreted using the HIV drug resistance 10-4 algorithm. We defined dual-class drug resistance as at least one intermediate or high drug resistance level in both NRTI and NNRTI drug class. And treatment failure was defined as 1 viral load above 1,000 and dual-class drug resistance. Suboptimal adherence to treatment was defined as plasma TDF concentration below 1,250 f-mol, corresponding to 7 doses a week. In total, 1,315 patients were screened, 316 were eligible, and among those, 305 were included for the quantitative part. And for the qualitative, 30 were included in the study. A total of 182 female and 125 males were included. The median age was 37 years in Kenya, 40 years in DRC, and the median time on earth 4 years in Kenya and 5 in DRC. The majority of patients included were on the standard recommended first-line TDF-3TC efavirenz. The median CD4 count was 135 in Kenya and only 69 in DRC, which is very low. The majority of patients included had CD4 below 200. There were 64% in Kenya, 84% in DRC, and a high proportion had CD4 below 100. We identified half of the patients with a TDF plasma concentration indicating a suboptimal adherence within the 3 last weeks. This table summarizes viral load results by CD4 count. As you can see in the first line, among all patients included, 37% in Kenya and 71% in DRC presented with virological failure. This is even more pronounced among patients with low CD4. Among patients with CD4 below 100, 68% in Kenya, 82% in DRC have a viral load higher than 1,000. And among patients with CD4 below 50, this is 84% in Kenya, 89% in DRC. Here I present the prevalence of treatment failure, defined, as I said, as one viral load above 1,000 and dual-class drug resistance. So reading the graph from the left to the right, if we take all patients included, which is the left bar on the graph, the overall prevalence of treatment failure is 26% in Kenya and 52% in DRC. Considering now patients with viral load above 1,000, 72% in Kenya and 75% in DRC have treatment failure. So in other words, 3/4 of patients with high viral load and CD4 below 350 are failing their treatment, as 2 out of the 3 drugs of their treatment are not efficient anymore. If we now consider the group of patients with a viral load higher than 1,000 and CD4 below 100, dual-class drug resistance was present in 75% in Kenya, 85% in DRC. And finally, among patients with CD4 below 100 cells, regardless of their viral load, 50% in Kenya and 68% in DRC have treatment failure. So I will now present the result of the qualitative component and only the common major themes. Our findings highlighted the complex pathway to care the patients are facing, and rather than arriving late, many had tried and failed several times to access advanced HIV early. To address advanced HIV early on within the health system. They were a group of patients who faced extreme vulnerability in terms of their mental health, experiences of stigma, intimate partner violence, grief and loss, with limited support structures. Patients arrived at hospital after a serious deterioration in their health, in a very bad state. Very often they had lost many kilos and are suffering from different infections. Most of them had tried to get help multiple times at facilities with missed opportunities to address advanced disease early on. At the same time, some had waited until a scheduled appointment to get help. Others had been discouraged to re-engage care because of provider attitudes. And we also know, as a group, that they are facing familiar adherence challenges over time, like difficulty with timing and overly strict instruction from healthcare worker on timing. We are talking about a mobile population. This is a quote from a patient describing his pathway to care. So he says, "Initially we decided to go to Kirondo Hospital. We went to Kirondo twice and Ponge once. There was no change. They would have taken me to the lab, but they had no electricity. So they gave me ERV for 1 month and I have not gone back. The health worker told me to call Mombasa. When the file is brought, they would put me in care this side. I was very sick. When we arrived, I was put on a wheelchair and taken to the ward." So it reflects very well the common challenges faced by the patient and the way they are referred from one health facility to another without improvement of their health. To summarize, our findings show a very high level of drug resistance among hospitalized patients with high viral load. They emphasize the importance of point-of-care testing at hospital level as a key priority to identify treatment failure. They suggest the need to rapidly switch some of the patients on first-line treatment with advanced disease as the treatment is not efficient anymore. So where viral load and CD4 test results are available without delays, then the focus should be on patients with viral load above 1,000 and CD4 below 350, as the majority of these are on an ineffective regimen. In the settings where viral load result is not available before discharge, then patients with CD4 below 100, the most at risk of dying, should be immediately switched to second line. Of course, this recommendation has consequences that need to be shared and discussed, and it could also be adapted to the context. Finally, additional studies are also needed to explore the benefits, risk, and feasibility of a fast switch to second line. Our findings suggest that actions must be taken not only at hospital level, but at the different levels of the healthcare system, specifically to ensure timely identification of danger signs at primary healthcare level, with ensuring an efficient referral system. And activity must also be strengthened at community level, including a system of post-discharge support at individual level, also to increase patient literacy and adherence. I would like to express my thanks to the MSF teams on the field, as well as all the colleagues involved, and of course, all the patients that participated to the study. Thank you.
Thank you very much, Claire.